Hello, we are Alehouse, a group of IO psychology scientist practitioners who created the behaviorally anchored rating scale for a position of a nurse. These bars were developed by Alana Zambetti, Liam Goley, and Erica Schultz. During our bars construction, we had 8 total steps, with the first step, developing critical incidents. When developing the critical incidents, we first wanted to conduct a job analysis. This job analysis was composed of information regarding a job description, KSAOs, and a structured interview that we had drafted for SMEs. There are a few steps that went into drafting the structured interview. The first step would be to make sure that these interviews are constructed based on characteristics that are actually reflected in the job and can be evaluated. When interviews are expertly drafted, they can link to macro and micro levels of analysis for these positions. We wanted all of our subject matter experts to receive the same questions compared to an unstructured interview method, which would give all 3 SMEs different interview questions. Utilizing a structured interview method also can help us utilize understanding non-cognitive skills that are related to the position and psychometric characteristics. This allows for us to understand a wide scale of constructs related to the position, as well as hiring the validity utilizing a structured interview versus an unstructured interview method. There were no shortcuts utilized in this step. Following this slide will be an example of the job description that was utilized, example of the KSAOs, and a sample of the SME structured interview questions that were used to conduct the job analysis. Following the job analysis was the development of our critical instance. As you can see here, this is an example of one of our critical instance that was then utilized to contribute to the job performance dimensions. With this, our critical incidents were then inputted into a survey for our subject matter experts. They were able to validate our critical incidents that were then used to become job performance dimensions. As mentioned, we decided to create job performance dimensions from our critical incidents. We utilized past research as well as SME input to develop these job performance dimensions. Another way we could have created these job performance dimensions would be to gather 3 SMEs to define these performance dimensions through an additional structured interview. We decided to take the shortcut of utilizing data from past research, such as the survey, to save time and resources for our SMEs. Since we did have 7 critical incidents that we had used, we had a lot of data to be able to create these job performance dimensions. Following this slide, you will see an example of our critical incident survey that was used to validate our incidents to then become job performance dimensions. In the next slide, you will also see an example of our job performance dimension listed out. Our third step in our bars construction was retranslation. This step included a KSAO task matrix as well as a KSAO scale and a task statement scale. When conducting the retranslation, we created a list of instructions for each chart that was utilized to understand which tasks and which KSAOs were relevant for the position. We implemented various tasks and KSAOs from ONET to put in our task and KSAO charts. These charts were rated on a scale of frequency of how often and importance, how critical. From 1 to 4, the frequency was rarely a 1, 2 sometimes, 3 occasionally, and 4 constantly. For importance, it was a 1 not important, 2 somewhat important, 3 important, and 4 critical. For the KSAO task matrix, it was on a scale of 1 to 4. 0 being not important with a description of each, 1 being somewhat important, 2 being important, 3 being essential, and 4 being critical with you cannot perform this task successfully without this KSAO. Those factors which passed through the KSAO chart and task statement chart were then put into the KSAO task matrix. Once we received data from the KSAO task matrix, we decided to conduct a factory analysis to then determine which items would be included in the next step of the bars process. The process of retranslation was implemented to check items and make sure that all of our task statements and KSAOs were relevant to the position of being a nurse. This is a promising procedure for this field in general. Utilizing our SMEs to understand the theory of these traits and behaviors was far more promising than utilizing observed behavior to understand what this position entails and what performance dimensions need to be developed or retranslated. With this, we decided to utilize a shortcut of using our recurring SMEs that we had used in the previous steps to prevent any extension of the retranslation process, as this can be a lengthy process and we were working with a short amount of time. Following this, you will see a sample of our KSAO and task charts, as well as a KSAO and task matrix instructions and criteria.
Hello, my name is Liam Gully, and I will begin speaking about the factor analysis that I conducted using the data from the KSAO task matrix. Essentially, this helped us identify variables that cluster together and look for patterns of correlation between the skills and see how they coincide. These are the results here. We have two patterns to look at, pattern 1, pattern 2. In pattern 1, you'll see skills that correlate together, and these high correlating skills best represent interpersonal skills. And we can see these are customer and personal service, medicine, and time management. For pattern 2, our highly correlated skills represent more so cognitive skills with active listening and complex problem solving. So we can draw a couple conclusions from this data. Firstly, nurses who are strong in customer service tend to be skilled in time management and have extensive medical knowledge. So they have knowledge information techniques for treating injuries and other issues with patients, and they understand things like drug properties, interactions, and can perform preventive healthcare measures, while also managing their time and time of others. Another conclusion we have here is nurses with strong listening skills also tend to be very good at complex problem solving. So they can identify complex problems and develop options and implement solutions while also listening, giving full attention to others, and understanding what they say and incorporating that in their problem solving. So following that last slide, we have the information I went over just in a format that's a little bit easier to read out and understand in terms of how the KSAOs correlate highly with each other. You can see that they're grouped with pattern 1 and pattern 2. And something worth mentioning is that there were recurring SMEs with the original data in the KSAO task matrix. So that is what we have here. For this slide, I identified the agreement on critical incident effectiveness from our subject matter experts. I took the data from our first survey that scored the critical incidents from 1, not very effective, to 5, extremely effective, and calculated agreement statistics for each one. This showed us how the subject matter experts agreed on placement of critical incidents and how effective each one was perceived by them. So if you look on our data on the left with the graph and the chart, you'll see that a critical incident with high mean effectiveness and low standard deviation are generally well agreed upon and effective. And a critical incident with high mean effectiveness and high standard deviation actually shows disagreement. So to better understand this, we can look at the standard deviation. A lower standard deviation means that there is high level of agreement among respondents and answers, so there's less varying scores. And a higher standard deviance means that responses are more varied and indicates disagreement. A shortcut we took in the case of the agreement percentage is that we lowered it from 80% to 70% because we felt that if 80% was the percentage we used to discard critical incidents, that we would lose too many at this stage, so we decided to lower it to 70%. For this slide, I took the data from our second survey, which dealt with evaluating the categories of critical incidents and their relevance of the nursing examples scored within those categories. These categories are leadership, communication, patient care, problem solving and critical thinking, and teamwork. You can see the table on the right that each critical incident was scored and calculated for the mean and standard deviation. So the mean for each critical incident and the standard deviation allowed us to assess the agreed upon effectiveness of each incident. The standard deviation allowed us to understand the consistency of each SME rating of each critical incident. So you can see here that critical incident 1 and 2 are very high. That's leadership and communication. And this shows that our SMEs generally felt that leadership and communication are being effectively executed in these critical incidents. You'll also notice that our lowest rated one is for number 4, critical incident number 4, with an average rating of about 2.89. This is most likely because the subject matter experts felt that number 4 did not represent leadership, and they thought it could be better off in the problem solving and critical thinking category.
My name is Erica Schultz, and I'll be walking through the process we followed in creating our behaviorally anchored rating scales, part 6, where we focused on categorizing the critical incidents. So we took the critical incidents that made it past the effectiveness survey and put them into categories that were created and defined based on common themes in interviews with nurses and ONET. And once we had them in these categories, we reached out to the same 9 subject matter experts that were involved in the first step. Their role was to evaluate the fit of the critical incidents in their respective performance categories and give feedback if there was a category they fit better in. And the nurses who took this survey showed a high level of agreement on the critical incidents and their appropriateness for each performance category. In fact, all of the critical incidents were placed in categories with a fit rating of greater than 4.5 out of 5 on average. However, with one exception, critical incident number 4, this particular incident had lower means, with the questions averaging with a 2.89 fit and 3.22 fit, with higher levels of deviation than the others. And based on these results and feedback for the short answer section of the survey, the nurses agreed that critical incident number 4 would be a much better fit in the problem-solving category rather than leadership. We chose to stick with the same nurses for this step due to time constraints and limited resources and access to additional nurses in the short time frame. And using the same group allowed us to maintain consistency while also being mindful of practical limitations. Following the 2 surveys and feedback from the groups of subject matter experts, we have our final list of critical incidents and their and the performance category that they fit into. So all of these critical incidents passed previous steps, and through this process, critical incident number 6 was cut because of a low effectiveness level. We did use a shortcut of having effectiveness of 70% or higher instead of the traditional 80%, just to ensure that enough critical incidents were made it to the final round to create bars for. So critical incident number 6 was cut, and critical incident number 4 was recategorized into the problem solving and critical thinking category. This leads us to our final step in the process, where we took the validated critical incidents and developed them into performance dimensions. For each dimension, the behavioral ankles have different performance levels indicating low, moderate, or high effectiveness. In the bars we created, level 1 and 2 indicate low effectiveness with descriptions. Level 3 indicate moderate effectiveness and behavior that meets expectations, and level 4 and 5 indicate high effectiveness. Here is one of the bars we created. In this example, a nurse is presented with an incident where they were found responsible for documenting patient information during a critical case. The competency is patient care and attention to detail. The performance category is patient care. And we have listed out the 5 dimensions of effectiveness and which level a person could be rated on, and some descriptions of what those behavioral indicators look like. As you can see in this example, the bars is designed to capture a range of behaviors associated with a particular performance category. In conclusion, we have followed the process of creating bars, from conducting job analysis and developing critical incidents to validating these critical incidents and their categories and dimensions through subject matter experts, and finally creating bars that can be used for evaluating performance. And we hope that this approach will lead to a more effective and actionable performance reviews in the Yale Hospital. And thank you